Thanks, Alex. I'm delighted to be here. Thank you. So I've been asked to give a brief from an industry perspective. So I thought the best way to do that from our perspective is to talk to you not about our personal perspective, because I think I'm as biased as you about doing challenge studies, since we're a contract research organisation which specialises in doing challenge studies, but to convey to you what our clients tell us about the reasons why they're doing the studies. So just a little add to that disclaimer, of course, I do work for HIC-Vac, and we are a contract research organisation absolutely dedicated in doing challenge studies. We've been doing them since 2001, mainly in influenza and RSV, but also some in rhinovirus. So we've done nearly 30 studies in flu and just over 30 studies in influenza. And of course, we have most recently done SARS-CoV-2 in collaboration with Imperial and many others from across the UK. So I think really I'm going to cover in two type of sections, really. Firstly, I'm going to give you some examples of why our customers have done challenge studies. And I'd like to say it's all to do with science, but it's not. So, which, that's industry. So, and secondly, we then consider some of that data and what are the limitations of challenge studies, and really to ask the questions, should we be doing challenge studies in all scenarios, and what we need to think about when we're designing these studies, particularly when we're thinking about efficacy of products. So why have our customers chosen to do these challenge studies? I think the first thing to point out is probably fairly obvious, but there are a lot of different reasons, and to be pretty generalistic, but small biotech often have a very different reason for doing it for the large biotech and big pharma. And really the big pharma are aiding internal decisions making. Sometimes there's fierce competition between completely different disease platforms internally about what to prioritize resources and funding on. And I'm sure Saranya and Kenya will talk far more eloquently on that from their perspectives, being in big pharma in the next two sessions. But I think small biotech have a completely different problem. Their problem is typically one of funding. So they come to us sometimes, often without any funding to progress, and they're working with us to design challenge studies because they know they need to get a proof of efficacy to be able to get funding. There's lots of different products out there, lots of small biotechs. What is going to make this stand out to venture capitalists such that they can get the funding to take their product into those phase 2, phase 3 trials? Well, it's a really big leap to go from a preclinical animal efficacy into a large-scale phase 2 or phase 3 trial. Rarely you get funding for that. So challenge studies in those scenarios are often a bridge to get to that point. And I think that they either want to raise money themselves to get to the next point, or they can be a really big inflection actually and raise the value of that company and therefore potentially get taken over. And I think there's numerous examples of this, but this is just one of the first ones which we came across in HIC-Vac, where we did a challenge studies for Alios Biopharma. This was an RSV, so it's an antiviral for RSV, and pretty much on the back of this challenge study data, which showed amazing efficacy, as shown on the right-hand side. You can see here, this is this is the dosing period, a 5-day dosing period. So we've got viral load. So on the top one is always the placebo group, and the others are the different types of active groups. So they all receive the drug in the active groups, but it's different type of dosing. So you can see they really knocked this out of the park in terms of efficacy. So viral load at the top, symptoms in the middle, and mucus weights. So on the back of that data, Alios Biopharma, relatively small company at the time, was bought for 1.75 billion. So that's an absolutely staggering inflection. I wouldn't say most of the purchases and acquisitions are in that scale, but even a tenth of that scale is quite a staggering inflection. So, and similarly, a more recent example is Reviral. So initially they did a challenge study with us, and again an RSV antiviral. They also had excellent efficacy data, and in their case they did want to take it through to the field trials themselves, and they have done that. But the money to go from Series A and Series B funding came off on the back of having this great efficacy data and demonstrating, yes, their product does work in humans. And that enabled them to get their next tranche of venture capitalist funding. And then subsequently, whilst that's still in the field and waiting to read out, of course, they've developed a next platform, a new generation of their drugs, even whilst the first one is going through. And they've recently been bought by Pfizer only this this summer for about 500,000, I think, so 500 million. So again, big figures. So moving on, so speed of data as well. So again, on the financial side, so small biotechs need to survive. It sounds obvious, but if they've got these great products, often some of them can be university spin-offs, some of them can be independent. But if you've only got enough seed money, but you haven't got enough money to even pay your staff, I mean, the whole concept can die, and it can be nothing to do with the efficacy of the product. It's just that you didn't get the seed money, the money and time to continue. So if you're thinking about doing a phase 2, phase 3, and sometimes it's an unpredictable time frame. We all know, particularly in the world which we mainly work in, which is respiratory viruses, of course, they're very seasonal, and you can chase the disease around the globe. And you think it might take you 2 years, but if there wasn't much disease around, it might take you 3 or 4. And in the life of a biotech, they might only have 2 years, and they can't afford to go for the 3 or 4. And in which case, the product dies purely because it didn't get the funding to go forward. So, speed of data is important. Challenge studies, of course, you know how long it's going to take. It's not seasonal, and you can do it in a very quick time frame. So they know they can go to the venture capitalists and say, look, you just need to keep me alive for 18 months. We're expecting to have a readout in 12 months. And the VCs can know that they can get that readout in that time frame. So the predictability of time frame, I think, is absolutely a crucial reason. Of course, they're all trying to gain proof of efficacy data, I think, but then we think about some of the more difficult scenarios. And I think some of the bigger pharma and the larger biotechs also consider using challenge studies, because when it's a proof of concept of a new class of drugs, for example, where it's considered slightly higher risk that they may not work. I think that's an example on that. So one such example for that one could be when we had a class of antibodies for the HA stalk, for example. There was a whole group of products came out against the HA stalk. It wasn't known if they would be neutralizing enough to prevent disease. So we had a number of challenge studies for commercial customers testing that concept. Better kill a product early than take it into phase 2, 3 and kill it late, right? So similarly, another specific example is some customers really want to have a broad spectrum label claim. Now, this might be within a disease. It might be for influenza. You might want to say it works against all influenza. Well, you go into the field and only H1 is circulating. How are you going to claim that it worked against H3? Or in this example on the board here is an example where we worked for Prep Biopharma, where their product is a poly-IC, which you give prophylactically by a nasal spray. So actually, it could work in theory against many different RNA viruses. So, but you've got to prove it. It's one thing proving it in animals, but proving it in humans has much more inflection and much more impact to get future funding. So they wanted to prove this against both influenza and rhinovirus, but in a short time frame. You tried doing that in a phase 2 study, and that can be very complex and huge timings. So they did 2 different separate challenge studies, both with the same product, to show their efficacy. And this is the influenza data, where you can see the blue there is the placebo, and in red received the poly-IC compound. So you can see they were able to reduce the total number of symptoms in flu. And here we look at a Kaplan-Meier plot of the duration of the more severe symptoms. So in the blue is the placebo, and you can see in the red here is those which received the drug, and you can see they were actually able to reduce the severity as well. So not just preventing, but reduce severity and duration of symptoms. So the other consideration is, you know your drug works, but you don't know exactly the optimal dosing regimen. Yes, you can do animal studies, but do they truly translate? Sometimes, but mostly not. So into phase 2, phase 3 studies, you really want to take your best possible dosing regime and work all of those questions out beforehand. So challenge studies, I think a really common utilization of doing challenge studies from a commercial perspective is to down select either completely different candidates against the same disease, or down select different types of dosing regimens. Dosing regimens is very common, particularly in the antivirals. We've got 2 examples here where we got a pedovir from Vertex, where you can see they tested lots of different doses. The black dots here are the placebo, so some efficacy for all of them, but not great efficacy. Really what showed then really showed the efficacy and made the difference was when a loading dose was given. So it really answered the question, yes, you do need that initial bolus loading dose before you then continue. And then it continued on to the field from there. So you can see you can have a much more then focused phase 2 study to be able to answer that key question and get the pivotal data. Similarly with Enanta, Enanta this is an RSV antiviral in this instance. The green is the placebo and 2 different active doses here. Both of those doses really had great efficacy. So then they went on to a second half of the study, actually, and then said, okay, what happens if we give it a bit later? Are we still seeing efficacy? So not just playing around with doses, but playing around with timing of the doses as well. So again, to then de-risk phase 2 studies down the line. It's no good just putting in your highest possible dose at the earliest possible time frame and kidding yourself it's going to work down the line. So obtaining efficacy before moving forward in difficult populations. So for flu, you can always move to the field typically. RSV, I think, is a really classic example where even the regulators, and I say even the regulators, have bought in. It's hard to get a regulator, as you know, to come out and publicly state, yes, doing a challenge study is a good way forward. RSV targeting infants is one such example where the FDA have quoted and have said you really should consider, if you've got a treatment, doing it in adult populations first. We all know they may not translate to babies and young infants, but if you think of that risk-benefit ratio, it's much more appealing if you can be sure that your product can work in adults. It's got a greater chance of working in adults. The viral loads are much lower. They shed for a much less duration than they would do in infants. So if it's not going to work in an adult, it really is not going to work in babies. It may not be the case the other way around, but at least it will stop those products going into that really vulnerable population which don't work at all. And we have knocked out a number of products from challenge studies. Of course, I put up here the ones which work, but there are some which don't work as well. That's because I'm putting up public domain data, and not always everyone publishes their negative data, unfortunately. So also sometimes, I mean, moving on to vaccines as well, I mean, we all know that there's lots of different strains and you're chasing the tail sometimes. So we've just recently partnered with Vaxart to set up Omicron challenge models. So moving on from the consortium, which we were part of for the original COVID strain, which was a pre-alpha strain. So Vaxart have got an oral vaccine, and of course nowadays, if you've got a new vaccine coming to market for COVID, you're now not allowed to do placebo-controlled studies in the field. They're considered unethical. So which means you have to do comparator studies, which are massive, because the N number you need to prove that yours is at least comparable is very much different, of course. When you're comparing placebo with expected no effect to an active, of course, you might need a much lower N number. So the barrier to entry for completely novel vaccines is very much higher. And if you're a small biotech, that just makes it even more difficult. And then the whole strain might change on you as well, right? So, and your vaccine may be good and be cross-protective against the different strains, but you could really throw the baby out with the bathwater if you go to the field, the strain changes, and it could have just been a tweak of your vaccine to make it be cross-protective, and yet you see nothing, right? So Vaxart are very keen that they wanted to get efficacy data in humans in a placebo-controlled study, but know what strain they're going to be testing against. So they're going to design their vaccine against Omicron, test it against Omicron. It may move on in the community in the intervening period, but at least they get proof of concept about their vaccine, and then they can come back and do either another challenge or move to field and do heterologous challenge. But at least they understand that initial concept: can this oral mucosal vaccine work? So it does have the advantage, of course, when you're doing these challenge studies, and it's the same advantage as a disadvantage. So in that sense, they're controlling the strain that they want to use, which is obviously in their case was an advantage. But equally, if you want to know if your vaccine is going to work against any type of strain, well, in the field you're going to be exposed to all the current strains. In a challenge, you're always going to be limited to what's currently available, and it's always going to be slightly behind the times because it takes a long time to produce a challenge virus. So I think that tees us up nicely for then to start to consider that we can't take it for granted that the model we develop is always going to be optimal and always going to answer the right questions. We do need to constantly evaluate how we design these studies and if they're really asking the right questions and giving answers that translate to the field. So what we're constantly doing is taking the studies that we do and look at those placebo groups and then compare them as a meta-analysis. I mean, the great advantage of doing challenge studies is you need a relatively small n number to get efficacy, but that becomes a disadvantage if you want to then extrapolate from that. If you've done a challenge study that's given you efficacy and you only had 15 in a placebo, how representative is that 15 placebo to 200 people? It means you're getting potentially an artificial read on the true variance. And then you go and do another study later on where you statistically powered only against that 15, and you wonder why you didn't meet your endpoints because your placebo looks a little different. Now, particularly where we're in an immune positive environment that most of the viruses we're working with, so everyone's seen at least a strain or two of flu, everyone's seen RSV. Yes, we can screen them, but we're not screening them for antibodies and T cells against all of the different strains. So we are going to get variance. This isn't a naive animal model. So on here you can see just an example of what we've been doing where we're plotting each of the different studies. Each line represents a different study's placebo group. So you can see they do follow the same pattern and the same curve, but the level of viral load is a little different. If we powered based on this purple one right at the top and had a primary endpoint of peak viral load, expecting to see nearly 6 logs, but actually our study came out as one of these green ones, nearly 4 logs, and clearly we've harmed our study ability to see if the drug or vaccine is working because we only powered on one scenario. So you need to understand the variance really to understand that. So, which is what we're doing. We're combining together, then treat it truly as a meta-analysis and keep running that analysis. And only by doing that do we truly understand the variance between subjects and the variance between studies, and therefore get better and better at powering these studies. And I think this is following on the RSV as an example. I mean, what we're showing here is those individuals which don't have any detectable disease. The green is the viral load, the bars are symptoms. Then if you split those who are technically meet the infected definition, you can see you get a range of severity, those with the classic high curves where symptoms correlate quite nicely with viral load, to those which have still good viral load but pretty wimpy symptoms, to those which barely meet the definition for viral load. So, and if you look at what we've done over time, when we first started doing these studies for RSV trigger dosing, the N number for the placebo group was typically somewhere around 12 to 16, depending on which group you're looking at. And they were successful studies. But then if you look back at why they were successful studies, it's because the antivirals at the time knocked it out the park. We did not meet the statistical assumptions that study was designed against. The placebo group was not as it was expected. And then if you take a step back and go, okay, it's fine if my antiviral has 90% efficacy, but how many antivirals are truly going to have a 90% efficacy? So, you could really be harming your model from that perspective. So nowadays, when we're doing these similar sort of studies, we're now looking at upping that quite considerably, and we're normally recommending 24 to 30 in the placebo group because you have a better understanding that this variance is normal. So you need to make sure your placebo group can be as comparative as possible. Only if your placebo group is normal can you learn anything about the efficacy of the treatment group, of course. So leading us on to that, so what other things do we really need to consider before embarking on challenge studies? And it's not always going to be the right answer to do a challenge study. Are we testing the same population? And I think the previous 2 talks really teed that up nicely. Your talk was excellent on the malaria in Kenya, and I think that really summarized really excellently this point. Actually, we can do malaria studies in this country where we've got no exposure whatsoever. You're going to get a very different response to when you do that in an endemic population. So think about the disease and think about, are we really targeting the right one there? So we have to screen our population to be able to inoculate them, because for flu, we've got pre-existing antibodies and they're not all going to get infected. If we didn't screen them, the infection rates would be so low. So of course, you're all familiar with the iceberg concept of disease. Of course, we know naturally you get many asymptomatic infections. And in the challenge model, we really see this sort of yellow area where you get some asymptomatic and no symptoms to moderate disease, but we never get right up to the top. Now, if you've got a product which is really, your TPP, your target product profile is severe flu, well, we're not going to have severe flu in this model, and I wouldn't want it either. I wouldn't be wanting to. We're basically doing these things safely. We have healthy volunteers and deliberately to control the safety. So we can't mimic severe flu. By the time it becomes severe, it's not really a virological disease anyway. It becomes more of an immunological disease. So we're looking at two different types of disease portfolios. So you can really kid yourself by doing a challenge study in that scenario if your product really, your mechanism of action is only targeted around severe flu. So single route of exposure. So we're inoculating all of our respiratory pathogens in droplets in the nose. Well, it does work, but is it the only route where you get infected from a respiratory pathogen? Probably not, right? Could be the mouth, could be all sorts of into the throat. So it could give you a slightly atypical. Yes, we may be able to mimic that, but that work hasn't been done. So we just need to be conscious of that, and particularly when we're thinking about how a product is administered. If it's an inhalation product and you're inoculating in the nose, and your product's designed to reduce lower respiratory tract infection, you may not even get the product to the same area you're inoculating. You're not going to see it, but it could work in the field because RSV and flu for severe will go to the lower respiratory tract. So you need to think about, is the product actually matching the model that we're using? And of course, how much are we dosing with? So we're always trying to give the minimum possible amount to cause a reproducible infection, but everyone defines that slightly differently. We don't have the luxury of working in a naive population, so I don't have the problem of having 100% infection. I'd love to have that problem, but that's not which we have. We're trying to get the infection rates up. But if you give so much virus that you get it up to that level, then of course it's going to be artificial. And if you're thinking in the vaccine context, the vaccine is not going to work because you've given so much it's going to overcome the immune response. So does that translate to the levels in the field? I don't know. That's very hard to see what is really the true levels in the field. So timing of exposure as well. So I've given this as a second example, this Gilead, because I showed it to you as a success story in the beginning. And it is in the sense that the efficacy data is fantastic in the challenge, but it failed in the field. And in the field, it was given very much later. And of course, the problem with all antivirals is how quickly can you administer them once you've tested positive? There's normally a very significant lag. It's not hours, it's days. So these early studies, particularly not in this case, this wasn't their ambition, but we do get from some very small biotech, they're just desperate to show the product works. So they go in with the highest possible dose that they can from their safety study at as early as possible time. It may show it works, but will it translate to the field? So, there's an ethical dilemma there. I think we are seeing an increasing trend of trying to convey to our customers to go in later to mimic more into the field, but they don't always want that. So high sensitivity as well. So it's great that we have these, in our challenge studies, they're all inpatient, so you can detect very sensitively whether they've got disease. So that iceberg concept, they may only just have disease. This person here, in the blue is symptoms, in the red is PCR. They would not have realized they got disease if they had been in the community. They wouldn't have even taken a headache pill, right? But yes, they met our definition. They are 2 positives by PCR. So we really need to think about those endpoints when we're designing the endpoint. If this was a vaccine, this was said, yes, I'm protected. But were they really? I mean, it's such a tiny level of disease. So you can really get the wrong outcome if you're not thinking about the disease severity endpoints, particularly what we find the problem is people who are used to designing studies in the field and want to use exactly the same definitions of endpoints. They don't work. I mean, if you think of flu, often you're taking the tip of the iceberg because as part of the recruitment, you're saying they must have had fever. Well, that's actually only the tip of the iceberg anyway. So, and this is, I think, Kassar also gave this definition in Shigella that the more severe the endpoint, the higher the vaccine efficacy. And this is just another example of that in J&J's RSV vaccine. So in summary, challenge studies do have significant utility to commercial companies. They do have a scientific outcome too, but it's not always scientific reasons why it's done. And I don't think we should be shameful of that. If it is a financial reason, that's good. It gives the finances to take potentially excellent products to the later stage trials to get the results that they need. There are numerous reasons for doing a challenge study. I think if people are testing products, they just need to be clear and honest with themselves about why they're doing that challenge study, and then design the study accordingly. And then that also then gives you clarity about really what the limitations are. Not one study doesn't fit all. If you try and answer all the different questions under one study, it rarely works. You end up not answering any of the questions. So care does need to be taken on study design. And there are always going to be certain limitations, but like I say, really to be clear on the purpose. If the means doesn't meet the end, then don't do it. Thanks very much.